Welcome everyone. Today, we're diving into the story of a 55-year-old woman with a medical past as complex as the symptoms she's facing. Imagine having a cough that won't quit, fatigue that weighs down every step, and fevers that come and go like uninvited guests. She's a kidney transplant survivor, and now, she's locked in a silent battle with an unseen foe. The CT scan reveals a shadowy gathering of nodules, with one so prominent in the left upper lobe it can't be ignored. But here's where the plot thickens. Every test for the usual suspects turns up nothing. No bacteria, no common fungi, no nocardia, no mycobacteria. The only clue: a positive marker in her blood screaming, fungal infection. With antibiotics failing to touch the symptoms, and a recent adventure in the great outdoors, the pieces of the puzzle begin to fall into place. Stay tuned as we investigate the signs, symptoms, and science behind fungal pneumonia, and uncover why it's a must-consider diagnosis in patients like her. Approximately 300 species of fungi are pathogenic in humans. Pathogenic fungi classified into yeasts, multicellular molds, and dimorphic fungi. Dimorphic fungi change form with temperature. Yeast form at 37 degrees Celsius and mold at 25 degrees Celsius. Endemic fungi affect specific regions. Aspergillus, Cryptococcus, and Pneumocystis are widespread. Fungal spores inhalation into alveoli can lead to pneumonia. So when do we suspect fungal pneumonia? The host factors affecting susceptibility. Immunocompromised individuals are most susceptible to fungal pneumonia. Certain conditions increase the risk, such as HIV, AIDS, cancer, transplant recipients, long-term corticosteroid use, and autoimmune diseases. CD4 plus T cells and neutrophils play a critical role in controlling fungal infections. Specific fungal infection risks vary with neutrophil and T cell levels, comorbidities, age, time from immunocompromising event, and antimicrobial prophylaxis use. Low lymphocyte count links to higher fungal infection risk, including Pneumocystis jirovecii. Chronic organ dysfunction, such as lung disease or cirrhosis, increases the risk for certain fungal infections. Even healthy hosts can contract severe dimorphic fungal infections if exposed to a high fungal inoculum. Emergomyces canadensis and Cryptococcus gattii can cause pneumonia in healthy individuals. This figure illustrates the pathophysiology of fungal pneumonia and how the immune status affects the progression of the disease. Panel A displays that with an intact immune response, inhaled fungal spores, or conidia, are promptly engulfed and destroyed by alveolar macrophages and neutrophils, halting any further fungal development or spread. Panel B shows the scenario during neutropenia or T-cell lymphopenia, where these defense mechanisms are compromised. Consequently, the conidia evade destruction, germinate into hyphae, and proliferate without check, leading to widespread infection and potential dissemination throughout the host. This contrast highlights the critical role of immune surveillance in preventing fungal pneumonia and underscores the vulnerability of immunocompromised individuals to such infections. The epidemiologic factors for fungal infection are: severe influenza or SARS-CoV-2 infection precedes increased risk for invasive aspergillosis and mucormycosis. Near drowning and drug injection increase the risk for specific fungal pneumonias. Candida pneumonia is rare and often represents colonization, not infection. Smoking cannabis or tobacco with fungal contamination can lead to pneumonia. Exposure to bird and bat guano is a risk factor for histoplasmosis and cryptococcosis. Travel or residence in areas endemic with certain fungi necessitates consideration of fungal pneumonia in diagnosis. Radiological findings suggesting fungal infections are: fungal pneumonia. Radiographic signs include upper lobe affection, nodules, halo and reverse halo signs, and vessel occlusion, suggesting angio-invasive molds like mucormycosis. Mediastinal lymphadenopathy hints at histoplasmosis or coccidioidomycosis. Pneumocystis pneumonia shows diffuse infiltrates and occasionally pneumatoceles or pneumothorax. Candida endocarditis may present with peripheral cavitary lesions. Non-resolving pneumonia after standard therapy may indicate fungal etiology, especially in endemic areas. Diagnostic workup for bacterial infection can reduce bacterial pneumonia likelihood, raising suspicion for fungal causes. Atypical infections and non-infectious conditions mimicking pneumonia should also be considered. How to start the workup for fungal pneumonia. Diagnostic steps for fungal pneumonia start with assessing host and epidemiologic factors to estimate pretest probability. Initial testing includes culture, microscopic examination, antigen, serology, and molecular tests. If initial tests are negative but suspicion remains, invasive diagnostics like bronchoscopy or biopsy and advanced testing like next-generation sequencing may be necessary. Culture is the definitive diagnostic standard, but quality specimen collection is essential for optimal outcomes. Elevated serum lactate dehydrogenase and AST-ALT ratio may suggest PCP or histoplasmosis, with eosinophilia indicating coccidioidal pneumonia. Various fungi grow at different rates, affecting culture times and subsequent sensitivity testing. Serologic testing for coccidioides is vital for diagnosing pulmonary coccidioidomycosis, with titers as low as 1 to 2 considered significant. High titers may suggest disseminated disease. Cross-reactivity with other dimorphic fungi is a limitation. Histoplasma capsulatum antibody testing aids in diagnosing both acute and chronic forms of its associated pulmonary histoplasmosis. Blastomyces serology is of limited use due to poor sensitivity and specificity. Aspergillus antibody tests, although less sensitive in mild cases and among immunocompromised patients, especially those on B-cell depleting therapy, are helpful in diagnosing chronic pulmonary aspergillosis and allergic reactions like allergic bronchopulmonary aspergillosis. Molecular testing, including pneumocystis jirovecii PCR, is highly sensitive for detecting pneumocystis, essential for diagnosing PCP, but may indicate colonization rather than infection if clinical symptoms are not consistent. Combining pneumocystis PCR with serum, 1 right-pointing arrow 3, BD-glucan tests enhances specificity for PCP. Aspergillus PCR, sensitive and specific for invasive aspergillosis, can also provide resistance data beneficial in areas with azole-resistant strains. A serum mucorales PCR assay shows promise for diagnosing mucormycosis in hematologic malignancy patients with high sensitivity and specificity. Broad-range PCR targets conserved fungal DNA regions, being most effective when microscopic stains are positive but other diagnostics fail. Routine broad-range PCR for clinical specimens is neither diagnostic nor cost-effective. Next-generation sequencing, NGS, despite low current utility rates for fungal pneumonia diagnosis, is promising, especially in immunocompromised patients with negative standard diagnostics. Research into fungal pneumonia diagnostics includes gas chromatography mass spectrometry for detecting fungal metabolites in exhaled breath, showing high accuracy for invasive pulmonary aspergillosis. Conventional diagnostics and diagnostic approach for specific fungal pneumonias. You can pause the video to read the details of individual fungus in details. As we conclude our exploration of fungal pneumonia, remember, vigilance and knowledge are our best tools in managing this elusive foe. Subscribe and click the bell icon right now to stay on top of the latest in medical insights. Don't go just yet. Stay tuned for this on-screen summary of an algorithm that demystifies the approach to diagnosing and managing fungal pneumonia. Equip yourself with this knowledge to enhance patient care and outcomes. Thank you for watching, and we hope this video has been informative and empowering. For more content that bridges the gap between medical theory and clinical practice, keep watching and join our community of healthcare professionals and enthusiasts. Until next time, keep learning, stay prepared, and take care.